Okay, welcome to chapters 13 and 16. We're going to talk about labor. Finally, you're in, maternity classes. So now we actually get into kind of the process of labor and birth, and of course, how to support our patients as well. This week, this is what you have going on. And then looking ahead to week 4 as well, of course, we'll be talking about this, and you've got your announcements. Make sure you look at your instructions to make sure you're doing your NCLEX questions correctly, and your CJ-SIM screenshots, of course, as well. And we've got an exam in week 4, your first exam, and so we've got the instructor reviews going on for that as well. Okay, labor and birth. So when we're talking about labor and birth, we just kind of a memory tool to talk about the 5 P's. And so we're going to break each of these down in the following slides. But the 5 P's that affect labor are the passenger, passageway, powers, the position of the mother, and the psychologic response. Okay, some people try to include pain as this one. Being in the 5 P's, pain is not one of them. It is more the psychologic response that the mother has to stress or pain or the process of labor and things, okay? So passenger, of course, refers to the baby itself and all the factors that go into that. Passageway is the pelvis, the pubic arch, the angle there, the vaginal opening. The powers are the forces behind the process of labor, which are contractions and pushing. And then position of the mother is kind of self-explanatory, but it certainly affects the passageway, can affect the passenger as well by adjusting the position of the mother. And then psychologic response, which we support with our encouragement and coping mechanisms. We'll get into each of these in the next slides. Okay, the first P is passenger, and one aspect of that is the presentation of the baby. Okay, so presentation, cephalic, cephalic means head down. So whichever the presenting part is the part of the baby that enters the pelvis first. Okay, so we're in the lower uterine segment, and the head is down. That's a cephalic presentation. There are some variations of cephalic because of the area of the head that is presenting based on how the baby's head is flexed or extended. So the baby could go in vertex, could be brow, or could be face presentation. If you look at the diameter of each of those, you can see that the occiput is the smallest circumference. So the occiput is the crown. That's like the very top of your head, not top like where the part of your hair is, but a little farther back, right on where you would see like the pointy part of a football. So that pointy part is the occiput, and that is a vertex presentation when the occiput is presenting, and that is the most favorable for birth. It's the smallest diameter. If you go further up to the brow, it's a much larger diameter that would need to go through the pelvis. It's also difficult for the baby to be making those turns with the flexion or extension of their neck. And then face presentation is nearly impossible. It is impossible. If the baby is presenting face first, then we have to go to C-section. So those are just some variations of cephalic presentation. And then we have breech presentation. So breech, of course, is basically bottom first, right? It could be the bottom coming out, or it could be one or both of the feet. So frank breech, you can see there, they have their feet all the way up by their face. Okay, so it's not like the fetal position like we think of it. They have their feet up, which is just kind of ends up being kind of funny because after delivery, they put their feet right back up there too, and they look funny the way they just boing their feet up by their face in a frank breech. And then complete breech is in the fetal position, so they're tucked just like, you kind of imagine a baby to be all tucked up inside, but they're upside down. So complete breech. And then footling breech is an actual foot or two coming out first. This type can't be delivered easily that way. Then there's you can see at the bottom of the slide here, it also mentions a shoulder presentation. In this one, the fetus is in a transverse or oblique lie, and the shoulder is presenting first, the scapula. That's rare, and of course, can't be delivered vaginally if the baby stays that way. Okay, so I mentioned the fetal lie on the last slide, but basically the lie means which direction is the baby lying. So it could be longitudinal, which is vertex or breech, or it could be transverse, where the baby is sideways, right, like east to west. Or it could be oblique, which is anything in between any of those sort of more 45-degree angles, that it's just not a proper presentation for delivery. So that explains the lie of the baby. And then the fetal attitude, it refers to the flexion and extension, which again, I mentioned in a couple other things, but I hadn't given you kind of the word for it. So the attitude, I like to think of this one as, if you've got this like teenager, in fact, that baby in the picture there looks like a teenager with some attitude. It's got its arms crossed, it's putting up its chin at you, it's acting like it's going to just stomp off into the other room and slam the door. So the attitude is whether the head is extended or flexed. Universal flexion is ideal because that is going to cause the baby to present the vertex, the occiput there. You can see how the crown would enter the pelvis, enter the lower uterine segment first if the baby stays in that flexed position. So universal flexion is ideal. Now this can happen basically if maybe the mom's uterus is an abnormal shape or she's got some anatomy going on. There could be other factors too, but that could be one possible reason. And as I mentioned before, if the baby is presenting with a brow presentation like that because they are extended, then it's going to be much, much harder or even impossible to deliver because the diameter is so much bigger trying to go through the pelvis and the vaginal opening, and it's sometimes not possible, and the baby sometimes can't make all of the movements it needs to, of the 7 cardinal movements, to make the turn as well. All right, and then we go into the fetal position. Position refers to basically the rotation in the uterus. So for this one, we refer to the mother's right side, left side, posterior, and anterior. And the ones at the very bottom of this diagram, ROA and LOA, are the most favorable for delivery. So right occiput anterior and left occiput anterior. And basically what this is referring to is where the occiput is. So you can see O is the middle term of all of these acronyms on this diagram. And that O stands for the occiput. So the question is, where is the occiput? What position is the occiput for this baby that's delivering vertex? Where is it in relation to the mother's pelvis? All right, so if there is an R in front, then the baby's occiput, and therefore like its back, its spine, is on the mother's right side. So if she's laying flat on her back, we would look, her right side, and we would, if we did Leopold's movements, should be able to feel the back, the long, smooth section of the baby's back. on the mom's right side. All right, and then similarly, if the baby's occiput is on the left side, we would be able to feel that on the mom's left side. All right, and then the last letter there, it's for anterior, transverse, or posterior. And again, that refers to the mom's anatomy. So if the baby's anterior, this is a really great position for delivery. It allows for all of the movements the easiest way and the smallest diameter possible. Transverse is hard because the diameter is larger side to side, and our anatomy isn't really made that way. And then posterior is difficult because this is when the baby, in layman's terms, we might call it sunny side up. And that is just a much more difficult way to go up underneath the pubic bone. The rotation and the flexion and extension can't occur as easily in that position. And this position is when moms complain of back labor a lot. Very commonly, OP positions, occiput posterior, are very painful back labors for moms. So those sunny side up babies, that's what we're talking about there. It's probably an OP baby. All right, so now we're getting into the passageway, and so we're talking about the openings in the pelvis and the cervix. So we're talking about effacement and dilation, and I just noticed a typo up in that title, but dilation refers to the opening of the cervix, of course, so that is how open it is, how dilated, right? It's from increases from 0 to 10 centimeters, and at 10 centimeters you can't detect the cervix at all. It has literally just kind of melted into the uterine wall. Effacement refers to the thinning of the cervix. So if at its full thickness it might be 3 to 4 centimeters thick, then at about 50% thick or 50% effaced, it might be closer to 2 centimeters, and so on and so forth. So that is a percentage of thinning. And once we get to 100% effaced, 100% thin, then we call that tissue paper thin, because you can be 100% thin, 100% effaced, but only, say, 6 centimeters dilated. And you have to find the edge of that cervix, and it literally feels like a tissue paper edge, and it's very, very thin, but 100% thinned out. Like, that's as thin as it's going to get until it dilates completely and you can't feel it at all. This video here, the link will take you to kind of an illustration of that, which is kind of a cool way to view it if you want to click on that link. It's also in your course resources page if you want to access it from there. Okay, now station. So station, it simply refers to how high is the baby in the pelvis. It is related to the level of the ischial spines, which is actually not depicted very well in these pictures now that I'm looking at it. But if you look at a model of a pelvis, the ischial spines kind of stick out here on the right picture. You can see it a little bit better, but it's something that you can feel on an exam. It is a difficult kind of part of the exam. It's difficult to detect these ischial spines sometimes. But once you've been doing labor and delivery long enough, you get a feel for where is zero station. And then if the baby is farther away from delivery, then that's a minus number. Okay, so the higher the baby is in the pelvis, the farther away it is from delivery, the more negative it is. And if the baby is -4, -5, it's really not even in the pelvis yet. It's not engaged at all. It's probably ballotable, which means we can kind of bounce it up and down in the uterus still. And then once you get to 3, it's kind of getting more engaged in the pelvis. And then -2 is getting closer to labor in general. Okay. 0 station is showing good progress, and then by the time we get to +2 station, we're seeing the head sometimes with contractions, and we're able to start pushing at that point. And then +4 is usually when delivery is happening, okay? So 0 station, again, is the level of the ischial spines. Here is a quiz question for you, or just a question to quiz yourself about where to best auscultate the fetal heart tones. And a little hint for you for this one is that the answer is you want to put, or a hint to the answer is that you want the fetal heart tones, you try to auscultate them along the baby's back. So you're going to try to find where is the baby's back, which side, and if the baby is head down, then we should be hearing the heart tones below the umbilicus. If the baby is breech, we might hear it above or transverse. All right, now the types of pelvis. 4 basic types that you need to know are gynecoid, which is the most favorable, and then platypilloid is kind of a long oval from right to left, and then android is a heart-shaped, and that's the most close to a male pelvis, and it's the most difficult to deliver through. Android is the worst pelvic type for delivery. And then anthropoid is also oval, but it's more of a long oval from front to back there. Okay, getting into now the powers of contraction, or the powers of labor, include contractions and pushing. So the reason that we're looking at all of these, quote, P's is because they all can factor into labor and delivery. And if they are going well, then labor is probably going really well. And if anything is dysfunctional with it, then labor is not going well anymore, and we're having problems. Okay, so the powers are a perfect example of that, as are all the other things we've talked about. But primary power is contractions. If we are not contracting strong enough or often enough, then we are probably not progressing in labor. If we are contracting too much, then we could be putting the baby in distress. So that obviously is a problem too. All right, and then secondary powers in pushing, bearing down, these that's important too. It's a lot more difficult for a mother to push if she has an epidural, oftentimes, because she doesn't have the sensation or the urge really to bear down. So that can sometimes play a big factor. It certainly is a factor in prolonging labor a little bit. Okay, process of labor. Signs preceding labor include lightning, which is, I've mentioned this to you before, but is easy to mix up lightning and quickening, I feel like. So think of lightning as engagement. It's dropping, the baby's dropping, engaging into the pelvis, and it makes it lighter to breathe, okay? The quickening, think of the baby kind of like running inside, and that's the first time the mom feels fetal movement. But anyway, signs preceding labor. Braxton Hicks contractions are starting to get stronger and more noticeable sometimes. Some people go their whole pregnancy and never notice Braxton Hicks contractions. I was one of those people. So some people notice them, some people don't. But either way, they're happening, and they are beginning to increase. A lot of times we'll put a mom on the monitor, and she won't know she's contracting at all. But they're still there, and they are increasing as you get closer to labor, because that's what your body does. Increased vaginal mucus is produced. Your cervix begins to soften, which of course only your healthcare provider would be able to tell you. You get that surge of energy, nesting, and bloody show. So bloody show is that increased vaginal mucus that occurs mixed with maybe a little bit of blood from some of the blood vessels bursting or breaking in that very vascularized cervix. So if your cervix is starting to begin to make changes, including this like softening, maybe beginning to open up, maybe beginning to thin a little bit, then you might expect to have bloody show leading up to active labor. And then possibly rupture of membranes. SROM is for spontaneous rupture of membranes. If you see AROM, that is artificial rupture of membranes, so that the provider broke her water. This is only a possible sign because it is very common that the water doesn't break before labor starts. And you know, you can even deliver your baby vaginally without having broken your water at all. Okay, it's called an in-call birth. And if the provider doesn't purposely break your bag of water, it is possible to deliver your baby with the bag intact, which is pretty amazing. All right, so let's assume that our patient, her water did break, or she comes in and she thinks her water's broken. One possible test that is at the bedside, it is becoming less common. I would say, like at our facility, we really don't even do this anymore, but it's a good, cheap kind of way to test and see whether it is possibly amniotic fluid. So this paper here, this pH paper you see, is called nitrazine. And you can press it up against the fluid. A lot of times what we would do is put it between the labia and ask her to cough or kind of laugh even, or do something to simulate movement and a little bit of pressure. And whatever fluid is there, if it turns blue, then it is probably amniotic fluid, because amniotic fluid is alkaline. And of course, if it's urine, if she accidentally peed on herself or something, then that's going to be a lower pH. It's not going to turn blue because urine is acidic, right? So anyway, that's a quick way to test. We also do other tests that we send to the lab for confirmation as well, but that's one of them. So if her water broke, then we are inspecting these 4 things, and the acronym you can remember is COAT. So C for color, O for odor, A for amount, and T for time, all of which are important. So the color we want is clear. It might have flecks of vernix in it, but we definitely don't want to see green or red. Okay, green would indicate the presence of meconium, where the baby passed meconium in utero, and that is a sign of distress for the baby, because they should not be doing that. They do that when they're stressed. For instance, if they had a Valsalva response from a low heart rate. Odor, it would indicate infection, and then we like to know the amount as well. It gives us an idea if she maybe was oligo or I can't think of the word for too much fluid right now, polyhydramnios. But it also just gives us an idea just for going forward. It can indicate even the engagement, because if the baby's low in the pelvis, then she might have just had a leak or a trickle, or maybe the it's only allowing a little to come out at a time. So that's just kind of good to know, but there could be many different reasons for the amounts. And then the time, because once her water's broken, she's kind of on a clock, if you will, that we want her to deliver within 24 hours. And if she's still not very close to delivery by 18 hours, then we're probably starting antibiotics, because we want to prevent infection for this mom and baby. And if she goes beyond 24 hours and she's not close to delivery, then they might consider a C-section in that case for that reason, for risk of infection. Okay, next is determining false labor versus true labor. This is that patient, of course, that's coming in for triage, and she's like, I think I'm in labor, or I don't really know if I'm in labor, and here's how we help her determine that. I'm going to skip to the bottom of this slide, though, on true labor and point out the bold words, because the only true test of whether a patient is in labor is based on her cervix. If her cervix is making changes, so effacement or dilation, that is the only way to know for sure, and of course only the healthcare provider can help her with that. However, if she's trying to decide whether to come into the hospital and be checked or whether to wait a little longer at home, the rest of these are an indication of whether you're in true labor, possibly, or if it's definitely false labor. Okay. False labor contractions are irregular. Okay, so this patient might have a contraction, two contractions 5 minutes apart, but then there's one that's 7, then there's one that's 10, and then back to 5 minutes again, until they are more regular than that. The kind of rule of thumb is every 5 minutes for an hour, then she can wait a little longer. It's not true labor yet, even if maybe it's early labor. All right. Also, false labor can be relieved. The discomfort can be relieved by taking a walk. You feel better when you're walking if it's false labor. If you're in true labor, then the contractions are going to progressively get more intense the more you are walking. And that's not just because walking necessarily makes it worse or whatever. It can help progress faster for sure. But true labor is going to progress predictably from 1 hour to the next, no matter what you're doing. Okay? In false labor, bloody show is usually not present because bloody show occurs when the mucus mixes with the blood as your cervix is changing, and then you have bloody show in true labor. So, of course, that's a big result of that is from cervical change. True labor contractions are often felt in lower back or abdomen. False labor contractions, that's not a really good one to rule out because somebody could be having back labor, somebody could be feeling, pain in their low abdomen, even in Braxton Hicks contractions. But if they're feeling pain from a contraction up toward the top of their abdomen, then that might be a false labor contraction. Okay. This slide is actually kind of new information, even in the last few years, about the phases in the first stage of labor. But just as a big picture first, I'll tell you labor is divided into 4 distinct stages. And it's only the first stage, really, that we think of labor. That's only the first stage because that is all the contractions, or most of the contractions, going from 0 to 10 centimeters, okay? And then once you're 10 centimeters, you're actually already in the second stage of labor, which is from 10 centimeters to the birth of the baby. So most of that stage is spent pushing, or at least allowing the baby to come down through the birth canal until delivery. Sometimes that is done more passively with an epidural in place, letting the body do a lot of that work. We call that laboring down sometimes. But that stage 2, ends with the birth of the baby. And then stage 3 is the placenta. Just think placenta for that. So from delivery to the birth of the placenta, or to the delivery of the placenta, we call, is the end of the first stage. And then stage 4 is the approximately 2 hours after that, which is recovery. Okay. So we're going to go over, each of these stages, but each of them has some unique kind of considerations. Labor begins because of hormone signals going on. Progesterone decreases estrogen increases, oxytocin and prostaglandins all increasing. So that's what the main medications we give to induce labor are: oxytocin and prostaglandins. Okay. We'll talk about some methods of induction here in a little bit, but regardless, they are attempting to bring you through the early phase of labor into the active phase, which is now considered to begin at 6 centimeters. So early is really 0 to 5. Active is 6 centimeters and beyond. There used to be, we would define transition as being from 8 to 10 centimeters. And we still see some distinct physical sort of indicators that mom is getting near to 10 centimeters. This is when she often will shake, or she'll say, I can't do this anymore. She'll vomit a lot of times during this transition phase, and those are cues to us to be maybe go ahead and check her, see if she's going through transition. What we used to call transition, or getting near to 10 centimeters is essentially what it is. And we would check her and see, because she might be making rapid change too. You'll see on this slide something that I said last slide as well, which is labor is defined by regular contractions and changes in cervical dilation and effacement. Specifically the cervical changes. All right. So labor is going to have, if it's true labor, then it's characterized generally by more regular contractions. But the main test of it is whether the cervix is dilating and effacing. If a patient needs to be induced, there are a couple different ways to do this. First, we would determine the Bishop score. The Bishop score is a series of, it's kind of a checklist, which consists of, is our patient already dilated at all? Is she closed? Is she 2 centimeters? Is she 4 centimeters? Is she thin at all? And it's got a different score range for whether she's thin, for whether the baby is, for the baby's station as well, whether the cervix is soft, and so forth. So the Bishop score will tell you whether she's favorable to have a successful induction. If the Bishop score is greater than 8, then that's a good score. You can find the Bishop score in your book, but if it's less than 5, then it's not recommended to start an induction at this time. It definitely happens, especially if there's a medical reason, but it is definitely going to take longer in that case. And if the Bishop score is low and we're inducing, then we're going to use cervical ripening first, because if her Bishop score is low, it's because her cervix is not showing that it is ready, because it's usually thick and undilated. So cervical ripening agents, there are a few different kinds, but they all contain prostaglandins. All right, so prostaglandins are interestingly the same hormone that is contained in sperm, which is why if you've heard that intercourse can encourage labor, it's not actually from the act of intercourse or anything. It's because he's essentially depositing prostaglandins right near the cervix, which is where we need it to be to get the cervix softened and ready for labor. So we have prostaglandin gels. This little circular picture up there is showing Cervidil. It is like a little insert, kind of looks like a small and flat tampon shape with a string, and we put it up near the cervix and leave it there for 12 hours and continue to monitor the baby, monitor contractions, of course. And then usually it will have made some effect by the end of that time, and if not, then we could do it again or try a different agent. But Cervidil is one, Cytotec is another one. That's a little pill, actually that contains prostaglandins that can be placed up near the cervix as well. Interestingly, it can also be placed, it can dissolve. She can put it like under her tongue or in her mouth. It can also be placed rectally and dissolved, and that's actually what we do if, in the case of a postpartum hemorrhage, you'll see this medication, Cytotec, again. We oftentimes will give that rectally, but a much, much higher dose than we give to induce labor. Another just interesting kind of thing that you'll notice when you're comparing, Cytotec and Pitocin are both medications that we give for inducing labor. They're also medications that we give to stop postpartum hemorrhage, to treat postpartum hemorrhage. In labor, the dose that we need is very, very, very small, and we have to watch it very carefully and make sure that we are not causing harm, which I'll talk more about in a minute. And postpartum, however, we give these huge doses by comparison, because postpartum, we need that uterus to really clamp down hard and stay that way. It's not even really, it's, you know, amazing because contractions, labor pains are painful with each contraction, right? But postpartum, that uterus is in a constant state of contraction and it's not painful anymore. Because most of the pain associated with contractions are thought to be related to the cervix, pressure on the cervix, dilation to the cervix. So anyway, just kind of be aware of that as you go through. So oxytocin there at the bottom, this is a high alert medication. We titrate oxytocin very carefully, and we want to make sure that we're preventing tachysystole of the uterus, which is contracting too much, too often. Contractions are too close together, or, well, mainly too close together, or too frequent, okay? In this picture here of induction methods, you can see prostaglandins. It looks like this picture is kind of blurry now, but the oxytocin drip, which we titrate very carefully, and then there's Amnihook, which is breaking the water. That is a more kind of natural way to signal the body that you want it to start releasing this endogenous prostaglandins and oxytocin. So it's, the body knows when that's happening. And then cervical balloon, there is a manual method of dilation where you add, it's basically like a Foley balloon on either side of the cervix, and you periodically add some more fluid until it basically manually dilates the cervix to about 4 centimeters, and that balloon falls out. Okay, in labor, there is what we refer to as the mechanism of labor, and that is a series of events, essentially, that occur as the baby is traveling down through the pelvis and the birth canal. So the very first one is engagement. That we've talked about that a few times. It's when the baby descends into the pelvis. If the baby is misaligned, we call that asynclitic. And so the baby would hopefully come down in synclitism. That's a hard word to say. But if the baby's asynclitic, layman's terms, we call that cattywampus, and the baby might be tilted forward anteriorly or backwards posteriorly. And that could make the baby have a different presentation as well, so like the face or brow presentation. In this slide, you can see the rest of the cardinal movements here. We talked about engagement as being the first one, and then descent, that kind of happens together. These are the movements that happen. They don't necessarily happen in this exact order. It could happen in any order, but as you can see, a lot of them kind of follow this general progression here. just because of what needs to happen as the baby comes down through the birth canal. But you can see the flexion there as the baby is kind of tucking its chin to go down under the pubic bone, and then the baby rotates, that internal rotation, and then as it goes underneath the pubic bone, it has that extension, so where it's putting its head back and extending. And then it's got the restitution and external rotation, so the baby actually rotates once the head is there on the external area on the perineum. You can actually see that when that's happening. You can watch the baby rotate, which is pretty amazing. And then the birth itself, expulsion. Okay, I mentioned that the second stage begins when the patient reaches 10 centimeters dilated, and usually that means that we're going to start pushing. Especially if she does not have an epidural, she's going to want to start pushing. She might spontaneously start bearing down. It is just a natural reaction that happens from increased pressure. And if she has an epidural, she might not feel that instinct, that urge. And sometimes if the baby's still a little bit high, so maybe at like a +1 station, we might wait and let the body bring the baby down a little bit more with some contractions. It would be up to the provider, because we're going to let the provider know when the patient is completely dilated. And if we would recommend that the patient labor down a little bit, we could say that, but it would still be up to the provider's kind of prerogative to say, no, I think we need to go ahead and try to get delivery going a little faster here. Laboring down can be great, though, if she's comfortable with an epidural, because it means that she won't get exhausted as quickly for all that effort that she's giving. When we are coaching her through pushing, we want to encourage open glottis pushing. So that is not holding your breath and bearing down. Doctors still love to try to do this, where they'll say, don't let that air out, hold it in and really push it out. But closed glottis pushing is not good. It decreases cardiac output. It can cause a Valsalva maneuver, and that decreases perfusion to the uterus, the placenta, and therefore the baby. Okay. It's common for this second stage to be 2 to 4 hours with your first baby, especially that longer range if you have an epidural. Still going to be encouraging position changes to help. You can imagine it's kind of, if you're trying to fit something into a tight space, you're going to move things around, try different ways, and it's the same thing. And even with the epidural, we can do some different position changes to try to help move the pelvis and even the soft tissues into more favorable positions for the baby to come down. We want to encourage relaxation as much as possible, especially in between, to really regain control, regain that energy, and to relax these tissues to allow the baby to come down. We don't want to fight the, what the body's doing. So comfort measures are going to be important here. She's probably going to feel hot. She's probably going to feel exhausted. We can give her ice chips and empower the support person to do that as well. Fetal assessment is, of course, really important here also. We're in the second stage of pushing, we're assessing the fetal heart tones every 5 minutes at least and documenting what they are. Most of the time we'll be monitoring continuously at this point too. Warm and cold compresses can be helpful, and having a good environment there, and making sure that we've got all the supplies and equipment that we and the doctor might need handy. So in a vertex presentation during expulsion, so the top of this picture, the baby is crowning. The provider will often put pressure on the perineum during the birth of the head. That's called the Ritgen maneuver, and that can help try to avoid tears. Then the shoulders are birthed. This is a very crucial moment where a shoulder dystocia could happen if the shoulder is basically stuck there under the bone. Then we have some specific maneuvers to do, which we'll talk about in the coming weeks. And then the delivery of the body and extremities is, comes easily after that. And then we are shifting focus to the newborn. I say that, it's not exactly true, because now it is standard practice for there to make sure that there's one nurse specifically for the care of the mother and one for the baby. At least one specific to each patient right at delivery to care for them. So if we're the labor nurse, we're not shifting care to the baby, but of course we are, especially for the baby nurse, we are paying attention to that. And that we'll cover in the coming weeks as well. Episiotomies are sometimes necessary, but they used to be very commonplace, and some doctors were kind of trained to just kind of perform an episiotomy willy-nilly, but now it is becoming much more kind of, I wouldn't say regulated, but definitely tracked, and goals are to make them in the low range so that it's, evidence that it's only being performed when actually necessary. So in the case of difficult deliveries or sometimes maternal exhaustion and things, the thought is that an episiotomy can help kind of open up the passageway better and deliver the baby. But episiotomies can actually, it's sort of like the idea of if you are trying to rip a t-shirt, you will have a much easier time if you cut it a little first and then it rips really easily. So the concern, one of the concerns, is that if you cut it, then it could tear even further. So I think we cover the degrees of lacerations, but just in case I don't have a slide on that, I'll mention it too. But the dotted lines in this little diagram are way too deep. Lacerations shouldn't go that far. So lacerations and episiotomies especially. So let me just start up here at the top and explain a little bit of each. So lacerations essentially just mean tears in the perineum or vagina or cervix or urethral area, okay? So what happens in that case is obviously the head being delivered tears the tissue, and then usually the provider needs to stitch it up to help stop bleeding and help the edges come together nicely, right? So perineal lacerations are the most common, I would say, and these are the ones that have first, second, third, and fourth degrees. So first degree is just like a surface thickness through some of the skin. Second degree goes a little farther through the tissue, and then third and fourth degree are a little easier to define, because third degree goes all the way to the rectal muscle, which is kind of what this red line here is showing based on kind of my opinion and view. And a fourth degree actually goes all the way through the rectal muscle, so that the opening between the vagina and the rectum is like one big opening, and you can imagine how terrible that would be for infection and things like that. So really, really not good. Even a third degree is very severe. Fourth degree is just really bad circumstance, right, for the mom. You do have, as far as classifying episiotomies, you've got the median or midline episiotomy going straight down, or the mediolateral kind of going at an angle there. Other lacerations include vaginal, which of course would be, instead of the perineum being between like the external area between the vagina and the rectum. Vaginal goes kind of the length of the vagina, right, going internally. Excuse me. And those can be difficult to detect, and so can cervical injuries. You can have cervical tears and cervical lacerations caused by the delivery of the baby, especially, you might figure that if the baby is, like, maybe you're trying to push over the cervix or through the cervix, or maybe you have a precipitous delivery, so everything just happens so fast, you could injure or tear the cervix. The problem is that these bleed a lot, and it can be very difficult to tell where the bleeding's coming from, because it's vaginal bleeding, it's postpartum, so there's bleeding there, but you don't really know why until you kind of roll it out and think logically. So what happens is, if we have a patient who we're massaging her uterus, and it's firm, it's not boggy, it's nice and firm, it's probably not the uterus bleeding, it's probably a cervical or vaginal laceration or some other undetected bleeding source there, and we need to investigate further. And vaginal and cervical lacerations cannot be assessed by the nurse. We can suspect it, so we're going to report to the provider we still have vaginal bleeding of this amount, because we're actually weighing and measuring the postpartum, we call it QBL, quantitative blood loss. So we know the exact amount, and if the fundus is firm and she's still bleeding, then it could be trauma. So trauma being a vaginal or cervical laceration, or some other maybe internal laceration that has not been diagnosed yet. That has to be assessed and diagnosed by the provider, not the nurse. But we can call attention to it for sure, and we can suspect what might be happening there. Urethral laceration is, as it sounds, it's more of a anterior tear on the vaginal wall up toward the urethra. Those are usually smaller, although they could be a significant tear there as well. But of course, those are easier to visualize and see, so not as much of a hemorrhage risk as some of the other ones. Okay, this slide is just a very short kind of summary of C-sections. There is, of course, a lot involved with the C-section, especially making sure the patient is safe and reducing risk of infection. So I'll just touch on the highlights here. In the pre-op stage, which the length of time that you have can vary depending on whether this is an emergency or scheduled procedure. But hopefully our patient is NPO. If she's been in labor, then she probably was limited to ice chips or at least clear liquids by the time she for sure has her epidural, but even in active labor, we're usually limiting some of the intake. She's going to have pre-op labs. We want to know her H&H and all sorts of other, labs that'll give us an idea of how she's doing compared to when we get her postpartum labs compared to pre-surgery. And then medications, we're going to give antibiotics, usually not until right before the incision, though. They should be ideally within 30 minutes of the incision time, but no more than an hour for sure. Depends on the guidelines, the recommendations they give there. But also Zantac, Bicitra, or Reglan, and these help kind of dry up the stomach acid, and so that reduces risk of aspiration for our patient. And then hair, referring here, is talking about trimming the incision site. So any of the hair near the incision site, usually we go kind of right down to the level of the labia, just to make sure it's all clear. Not down by the labia, but the just the mons area. down to closer to where like the urethra would be. We use clippers, we don't use razors, and we don't want our patients to use an actual razor because of the microscopic nicks that occur. All of those can be causing a risk for introduction of infection. So we use clippers, not razors, and we don't want our patients to use a razor. SCDs are very important. They need to be on the patient, preferably prior to going back to surgery. And then we make sure they're hooked up all through surgery. Remember that during pregnancy, our patients are at an increased risk for thrombus, DVTs, and could become a pulmonary embolus. And all of those, of course, are very dangerous. And we want to prevent that with SCDs. Sequential compression devices, if you're not familiar with that one, they kind of inflate and deflate and help circulate the blood in the calves. We're going to, of course, provide all the education that we can. Foley catheters are also needed. At my facility, we do the Foley catheter after anesthesia, and so she's not, feeling that. We also do a vag prep, so we're going to prep the belly, like the incision site and all the way up the belly with ChloraPrep or betadine. But we'll also do a vag prep to basically sanitize anything that might be exposed to the baby traveling up the vaginal vault as well during surgery. All right, and then post-op assessment, of course, the things that we are going to assess differently in our post-op patients, as opposed to just our vaginal delivery postpartum patients, would of course be the incision site. Okay, we're looking for signs of infection, signs of dehiscence there, so excessive drainage, redness. It's going to be tender, obviously, but it shouldn't be puffy and extremely painful, and shouldn't be, hot and sore around the incision site. We're going to mark any drainage each time we assess it as well. And we do still have to do fundal checks on these moms, even though, it's going to be very sensitive for them. We have to assess their fundus, and if it's boggy at all, if it's soft at all, we need to massage it too. Okay, caring for our babies. We're going to learn a lot about this later in the term, but the basics of the immediate care of the newborn are, if the baby is doing well right at delivery, we will put the baby skin to skin. The cord usually doesn't reach all the way up to the chest, and the baby is still attached to the cord for I think most facilities probably do delayed cord clamping standard now, for at least 1 minute, sometimes 2 minutes, and some people might request to leave the cord attached and unclamped until the cord stops pulsating, because this can help increase the fetal placental blood volume. It helps pump the extra blood, oxygen, nutrients, and if you think about it, the baby is transitioning from 100% reliance on the placenta to 100% reliance on breathing in oxygen through the lungs, just like this, right? Just with over, a few seconds. So allowing that extra time to let the placenta do its job can help with that transition for the baby. Now, of course, if the baby's already in distress, if the cord was already not getting what it needed to the baby, then we sometimes need to clamp immediately and take the baby over to the warmer and start resuscitation. This includes things like if the baby has a nuchal cord or a tight nuchal cord, or maybe even 2 or 3 nuchal cords wrapped around. Sometimes that cord has to be clamped and cut even before the body's delivered, because it's just that tight of a fit, and has to be done. But the preference is to be able to allow time for that transition, and that it can be good for the baby. There is a small, it's a higher risk for jaundice, essentially, because there's more blood volume, more red blood cells are also kind of breaking down, which breaks down into bilirubin, which we will learn more about later. But the other benefits to the baby are greater than the risk of that jaundice, so it is recommended. I already mentioned we're going to have 2 nurses at birth at least, one focusing on mom's care and one on the baby's care. And we take APGARs at 1 minute and 5 minutes, and other vital signs as well. The next slide, we're going to talk about APGARs, and again, we'll get more detailed on this as the term goes on, but we'll start on it now. So APGARs use a grid, system of points where there are 5 categories, and the APGAR is actually an acronym to help you remember what those categories are. And each category will get either 0, 1, or 2 points. So A is for activity or muscle tone. And basically, if there's no activity or muscle tone, so the baby comes out just very floppy and limp, then that baby would get 0 points. And to get full points, they would be actively moving. So you have your baby that's usually crying, right? And they're kicking and screaming, basically. Punching, kicking, screaming. The pulse rate is the next one. So if there is no heartbeat that we can detect, then they get 0 points. If it's over 100, so this is a little different than our fetal heart rate monitoring, right? 100 instead of 110. But if it's over 100, they get the full 2 points. If it's less than 100, they get 1 point. And this is at 1 minute, remember? So we have a full minute to allow the baby to kind of recover and, catch their breath, if you will. It's not like, okay, the baby's born and now immediately I have to assess what's going on. We assess at 1 minute old, okay? Grimace is their reflex irritability. So this is like if we are kind of like flicking their little feet or kind of rubbing, maybe rubbing their back or rubbing the bottom of their feet. If they have no response at all, then they get 0 points for that. If they respond a little bit, then they get 1. And if there's active motion, like pulling away from us, then they get 2 points. This also mentions sneezing and coughing, so just kind of some of those reflexes can count as 2 points for that. All right, and then appearance refers to the skin color. Completely blue or pale is 0 points. Completely pink is 2 points. Completely pink is pretty uncommon and rare, actually. Most babies will get 1 point in this category, where their body is pink but their extremities are blue. And that's just because of their circulation. That's called acrocyanosis. And it's normal in the first 24 hours for as long as their trunk is blue. As long as their trunk is pink, their hands and feet can be blue, and that's still within normal. All right, and then respiration. So if you have a baby or you see like a word problem that's talking about how the baby is crying vigorously, then that refers to the baby's respirations, because in order to cry vigorously, you have to be able to breathe very well. And so a vigorous cry gets 2 points. No cry is 0 points. And if it's slow or irregular, that is 1 point. Okay. All right, moving on to the 3rd stage. So our baby's born. We've gotten through the 1st stage, which is labor, the 2nd stage, which is pushing and delivery, and now we're at the 3rd stage, which is the placenta. So 3rd stage, we are very actively looking for complications here. You might have just heard my dog barking. And the main complication we're looking for is bleeding, postpartum hemorrhage, okay? Oftentimes the placenta will be delivered within about 5 minutes, but the longer it goes, and then up to 30 minutes can be considered normal. The longer it goes, the more at risk the mom is of hemorrhage after that. And partly that's because basically if the placenta is super well attached, There's more of risk too because the provider might be pulling on that cord, might be forcing a separation, which leaves some of what's attached behind, and that prevents the uterus from really contracting very well and stopping the flow of blood. But also there could be other issues going on, and that all increases the risk of hemorrhage. Here the guidelines say 15 to 30 minutes. 5 minutes is also, common and normal. And that is the third stage. So it can be a very short stage, and usually is really, but it's something that we need to kind of be on high alert for. And usually we're also administering Pitocin. Let's see what the next slide says about that. So we are, this term, expectantly managing and actively managing, that means we're anticipating that blood loss is a very real risk, and we are working to try to minimize that. One of the main ways we do this is by administering oxytocin. The facility you're at might vary. So it used to be that you wait until after the placenta is detached to start the Pitocin. Sometimes now they say as soon as the baby's born, you can go ahead and start that Pitocin, and it's a bolus of Pitocin. Up till now, we've been titrating it, so we'll start it during labor to induce contractions. We'll start with 2 milliunits a minute, up to 4 milliunits, and then up to 6, and we go up by 2, and the most we'll give is 20 milliunits per minute, unless we have other special orders. Well, when you are when you're postpartum, we are all of a sudden bolusing a lot of Pitocin, and then we're going to give it at a high rate for a little while after that, usually up to that 4-hour mark. So that's just to kind of contrast here, but to show that we're expectantly managing, we give oxytocin to everybody to help encourage that uterus to really tighten up and prevent excessive bleeding. We're also massaging the uterus after the placenta is delivered, which after the placenta is delivered, that's technically into the 4th stage, the recovery stage, but it's all happening there, pretty quickly. So we're massaging the uterus, which also encourages the uterus to really tighten up. During this stage, we also collect the cord blood. That'll give us the baby's blood type, and then we'll know whether we need to treat mom with RhoGAM if she's Rh negative. Okay, question here. The rest of these slides are also practice questions, and I won't go through all of them because you can go through them yourself and kind of quiz yourself. But I like to talk about this one because it's talking again about umbilical circulation, just to kind of remind you and quiz you. So umbilical vein values indicate blank function, and umbilical arterial values reflect blank at birth. I think that's just 1 blank, not 2. I could be wrong, we'll see. And then this note, assess the umbilical cord acid base after delivery if the APGAR score is less than 5 at 5 minutes. So our babies can be acidotic if they were stressed in utero, and our fetal heart rate tracing can tell us whether to expect that if we're looking at it and interpreting it, right? So remember, the variability will tell us how well oxygenated is the baby at that moment, and the absence of accelerations might tell us that the baby is acidotic, okay? Meaning there's a little bit more implication there for how is the baby being affected at this point. Have they been deprived of oxygen long enough that now it's really affecting their acid base status, okay? So the umbilical vein values indicate the placental function, and the umbilical artery values reflect the fetal condition at birth. So let's think about this a little bit. So the umbilical vein is going, remember, veins travel toward the heart, and our arteries are pumped from the heart back out away from the heart, right? But because the umbilical vein and artery are, the placenta is actually where you're picking up oxygen, what's happening is the baby's pumping from the heart toward the placenta because it needs to gather oxygen. So this is unoxygenated blood going towards the placenta, and then it picks up oxygen in the placenta, and as it travels back to the baby's heart to be pumped out into the body, that's oxygenated now. So the vein traveling toward the baby's heart is what carries the oxygen. So the umbilical vein is coming from the placenta toward the baby, which will tell us the placental function. So what, in ideal situation, how was the oxygenation in the placenta? And then the artery is the blood that has already been used up, whatever available oxygen was used by the baby and is being pumped back to the placenta. That's going to tell us the fetal condition. So the umbilical artery is the value that will best tell us the acid-base status of the baby at delivery. Again, this can be a complicated kind of thing to wrap your head around, but the more you kind of hear it, the more you think about it and kind of visualize it in your mind, you can imagine that. So in this cord here, just like in adults, the vein is this big, fat, dilated one. And the artery, one of the arteries, you can just barely see. If you look at that very top loop, it is a very dark blue, and it's much smaller beneath that big purple one that's wrapping around. You can see one artery there. That could be where you would puncture and collect your sample. So as I said, I'm not going to go over all the other questions with you, but we do have a little bit left on stage 4 recovery. So remember, stage 4 is the recovery period, usually considered the 2 hours after birth. We are assessing blood pressure and pulse frequently, every 15 minutes for the first hour. And why is that? Again, because postpartum hemorrhage is our biggest risk here. So we are really actively assessing our moms, and we are assessing the fundus every 15 minutes. We want it to be firm, not boggy. We want it to firm up. And right after delivery, we'd expect the fundus to be right at the level of the umbilicus, okay? Sometimes it can be tighter than that and a little lower, but we definitely don't want it to be higher than the level of the umbilicus, because that is going to show us that something's wrong. It's not clamped down like it should be. Maybe it's filling with blood even, and there's clots developing in there, which can happen. But also we need to make sure that we're keeping her bladder empty, or at least after just a few hours, we need to make sure she's emptying her bladder. The bladder being full can prevent the full contraction of the uterus and can contribute to increased bleeding because of that. And one way to tell is when you're doing a fundal exam, if the uterus is deviated, it's high and to the right side, then that is an indication we would suspect that her bladder's full, and we need to try to get her to void. If she can't stand up yet, we'll void attempt on the bedpan. But sometimes, especially if she's had an epidural, she might not have that sensation and ability back yet. So sometimes we actually need to do a straight cath to drain her bladder for that first time, and then attempt again for the next void. Fourth stage, we're also assessing lochia. Lochia is the term for postpartum bleeding. And lochia, we would expect it to be bright red for the first 3 to 5 days. And then from about 3 to 10 days, we would expect it to start changing to be more pinkish, okay? And then after 10 days, we would expect more of that lochia alba, which is more white. And then the main thing is we don't want it to revert back the other direction. Once you've healed enough to not be passing red blood anymore, then it shouldn't be going back to red again, and that's a warning sign. Also, passing clots is a warning sign. We don't want her to be passing clots, and we want to be watching her really closely. And then, of course, during recovery, we're facilitating breastfeeding as well. There's a lot more to go along with this, again, as the term goes on, but this is just kind of the first kind of introduction to the labor and birth process. As always, reach out if you have any questions or needs, and I'll click through these practice questions here as I'm wrapping up so that you can, if you'd like to, you can kind of look at them and pause. I probably need to move that video though, that's blocking some of it there. You should also have the basically these slides as well that you can look at and possibly print. This little summary here, there's actually a few slight things that have changed just in the last couple of years. I mentioned at the beginning of this lecture that one of them is the phases of labor, so this first stage here. And even these phases in the second stage, they're much less rigid on, that they don't require you to know these phases or anything. So it's just kind of good informationally to think about. These transition phases are not even really part of the vocabulary anymore, but it's still something that usually happens. So it's a good kind of idea to just kind of look at and think about. So happy studying. Thanks for watching. We'll see you soon.